it's been used up front now in the adjuvant setting. But unfortunately, as a group of patients, despite getting Herceptin in the adjuvant setting and despite getting Herceptin in the metastatic setting, eventually some patients will develop refractory disease to Herceptin. So what new drugs and what new agents are there for patients with HER2 positive disease? Well, the first drug is a drug called pertuzumab, and it's like Herceptin. Herceptin is called trastuzumab. This is pertuzumab. It works a little differently from Herceptin, but it's been shown to be a very effective therapy for patients who progress through Herceptin-based therapy. So this pertuzumab was a large trial. We were not involved in pertuzumab, but the response rates were very high, surprisingly high for patients who progressed through trastuzumab-based therapy. A second drug that we heard a lot about at ASCO was a drug called TDM1, and TDM1 is basically Herceptin conjugated to a chemotherapy, and the chemotherapy is called Mytansine. And so the Herceptin is coupled to the Mytansine, and basically what you have is that the Herceptin gets targeted to the cancer cell, and then the Mytansine goes into the cancer cell, almost like a Trojan horse. And in patients who are refractory to Herceptin, when they use TDM1, we saw a remarkably high response rate of almost close to 50% with very little toxicity, no hair loss, an excellent drug really. And again, we were involved in that trial. We put a number of patients on TDM1. It's likely to get approved sometime, maybe next year, and it's just another agent that patients with HER2 positive disease that's refractory to Herceptin will have access to. A third drug that is close to being approved is a drug called neratinib. And neratinib is what we call a small molecule tyrosine kinase inhibitor. So it's a tablet, and it's very much like lapatinib, but it works a little bit differently. Lapatinib is a drug that is approved for HER2 positive metastatic breast cancer that's progressed on Herceptin-based therapy. So for patients with HER2 positive disease, there are many new exciting agents out there. And if a woman's unfortunate to develop metastatic disease or develop HER2 refractory disease, there are many agents out there that will make their disease a chronic disease rather than something that's immediately life-threatening. So for patients with triple-negative disease, as we all know, this is a somewhat aggressive subtype of breast cancer. It makes up about 15% of breast cancer. It tends to be seen in younger women. It also tends to be seen in the African American population and the Hispanic American population. It's also classically seen in patients who have BRCA1 mutations. It can also be associated with interval cancers. So what I mean by that is a woman has a mammogram, she's not due another mammogram for a year, and then she develops an interval cancer between her mammograms. And quite often that is a triple-negative cancer that tends to be more aggressive than your estrogen receptor positive cancers. These cancers respond very well to chemotherapy, but unfortunately they are associated with a higher risk of recurrence within the first couple of years. So we tend to keep a very close eye on patients who have early stage disease, who have triple-negative breast cancer. But it is very sensitive to chemotherapy, but there's just a slightly higher proportion of patients who recur in the first 2 years. But the good news about triple-negative disease, though, is if you're not one of the ones that progresses in the first 2 years, survival is actually very good. The chance of recurrence at year 3, 4, 5, 6, 7, moving on, is actually much lower. So recent data from ASCO suggests that there is actually great heterogeneity within triple-negative. So triple-negative isn't just one disease. Even within triple-negative, there are subtypes that are more aggressive than others. And one important piece of information that we learned about at this ASCO, this most recent ASCO 2010, was that there's a protein called Claudin, C-L-A-U-D-I-N, which is expressed in a subpopulation of patients with triple-negative breast cancer. And these Claudin-low triple-negative breast cancers are actually unfortunately associated with a much worse outcome than other triple-negative breast cancers. So you might find that in subsequent and future trials of triple-negative breast cancers, patients with Claudin-low disease will be will be taken out and perhaps treated in a slightly different way, perhaps in a more aggressive way. But this is very new research that's coming out, and certainly moving forward, I think checking for Claudin in patients with triple-negative breast cancer will be done. As we all know, a very promising new drug, a new class of drugs for triple-negative cancer has been tested over the last 2-3 years. These are so-called PARP inhibitors. And PARP inhibitors have been shown to be very effective when added to chemotherapy, particularly platinum-based chemotherapy in patients with triple-negative breast cancer. There was a large phase 2 trial presented at last year's ASCO that showed a significant survival benefit for PARP inhibitors, and we've subsequently gone on to do a randomized phase 3 trial, which is the definitive trial which could potentially get the drug approved for patients with triple-negative breast cancer. And again, proud to say that VOA and our patients here, community at large at Hampton Roads, put on more patients on this triple-negative trial than anybody else in the country. I'm going to move on to early-stage breast cancer. So, unfortunately, in early-stage breast cancer, disease that's within the breast or within the local regional lymph nodes, there wasn't much new to report from ASCO. This was an ASCO that there weren't very large randomized trials that were reported about patients with early-stage disease. Most of the important new information actually came from in early-stage breast cancer has come from surgeons and from the radiation oncologists. There's some emerging data that not all patients, for example, who have a positive sentinel lymph node necessarily need to go onto an axillary dissection. It was an important trial presented by our surgical colleagues at ASCO, suggesting that in a subset of patients anyway, moving on to an axillary dissection after sentinel lymph node certainly may not improve survival and may not even improve local recurrence rate in terms of axillary recurrence. But not my area of expertise, and I don't want to step on Dr. Reed's toes, so we'll let her talk about that, because it is somewhat controversial, and we have expert surgeons in the community, including Dr. Reed, who can certainly talk to us more about that. There's also, from our radiation oncology colleagues, there was an important trial that showed that not all women necessarily after lumpectomy need radiation. So there's a very small subset of patients who are greater than age 70 who have estrogen receptor positive breast cancer. It was a trial in which patients were randomized. They all received anti-estrogen therapy appropriately, they were all ER positive, and they were randomized to radiation or no radiation. And there was an update in this trial that showed that there was no survival benefit in these women over 70, whether they got radiation or not. There was an increased risk of local recurrence, but it didn't result in an increased risk of death. So certainly for women over 70, it's a discussion such women can have with their radiation oncologist as to what is the true benefit of receiving radiation in that setting. Again, I don't want to step on toes. I'm not a radiation oncologist, so I'll leave that to Dr. Archie in our meeting as well. The radiation oncologist presented some data about partial breast irradiation, suggesting that partial breast irradiation or brachytherapy, so higher doses of radiation just to one spot in the breast,